When I come in, I was a mess. You might not be able to see it now, but I'm a totally different person, and it's only due to the staff and all they're working.
Well, we're really focusing on central line bloodstream infections and trying to prevent them. As you know, in an acute care hospital with patients who are immunocompromised, who may be on chemotherapy, maybe on radiation therapy, transplants and so forth, infections can be devastating.
Anyone having a central line inserted has a risk for an infection, but when you couple that with an oncology patient receiving chemotherapy and then they become neutropenic, which means the infection fighters in their blood have been suppressed, they are sitting ducks for that infection.
So it's really about preventing those infections before they happen, before patients get into trouble.
Where I first heard about it was at our monthly leadership meeting, and the presentation was excellent. I took these initiatives that I had heard at leadership to my staff.
And so we got together. Kate has already talked to the person in interventional radiology, and almost all of the oncology lines are started in interventional radiology. It gave us an excellent opportunity to control both the insertion bundles and the maintenance bundles with this patient population. So we identified that other people that needed to be involved on the team were our infection control people, our outpatient chemotherapy persons, as well as our venous access consultants. And we also included a medical oncologist on that team as well to try and round out the team and make sure all the stakeholders that were important were involved.
Prior to the Safer Healthcare Now initiative being implemented, our bloodstream infection rate was 3.5 line infections per 1,000 line days. And sure enough, when we looked at our data, particularly the fourth quarter of 2006, we certainly did see that there was a significant decrease, and we were sitting at 0.6 line infections per 1,000 line days.
Often teams aren't even aware of what their infection rates are or having the understanding of how much they can be reduced. I think for spread in our organization now that our whole plan will be to identify key areas that have room for improvement and share with them the successes of this oncology team as well as some of our other teams that have been made, and I'm sure they will be eager to participate now.
So we're absolutely proud of them. It's great. I always view it that our senior team's responsibility is to set the stage and the plan, know what we're supposed to be doing overall for patient safety, and then sort of take a step back and get out of the way and let our teams go for it. And so we have a board website that tracks each one of our strategic initiatives, including patient safety, making sure that we're doing all of the efforts we have on Safer Healthcare Now. They have that tool that they can dial into at any one time to see where things are going. And as I said, through quality and performance and through the Medical Advisory Committee, there's a regular reporting stream to how successful we're being.
With this type of system and the close observance they've had, it's obviously they're working their hardest and doing their best to reduce all this possibility of infection coming in, which has to make us all feel that much better.